Okay, I think we'll start. So welcome back, everyone. Hope you had a good break. Wasn't Dr. Louise's talk amazing? Fascinating how neuroimaging helps us to understand brain behavior relationships. And he makes it so easy to understand. And we just want to thank you so much, Dr. Louise. The next speaker is probably known to most as the neuropsychologist who knows about 99.9% of what there is to know. And he also knows
my God.
Recipients of the Len Koziel Student Poster Award. So Dr. Paul Belgian will be introducing him. Take it away, Dr. Belgian.
Hi, this is Paul Belgian. I'm doing Pete Dodzik's introduction, and he has a lot to talk about. So he asked me to actually just not sit and read all of his background here. Anybody who knows Pete knows that he is a really smart guy, very friendly and approachable, extremely accomplished clinician. So in lieu of doing his background, I thought I would tell an anecdote. Now, as you can see from his picture, which is very old, I've known Pete for about 15 years or so. And when my wife met him, she goes, wow, he looks like John Stamos. I'm like, yeah, you know, he's a really good looking guy. She goes, well, you look like Brad Pitt. And I go, well, Jyoti, we need to get your eyes checked. So after she got her glasses, she's like, nope, he still looks like John Stamos, but you look Sloth from the Goonies. So with that, so she doesn't wear glasses around me. With that, Pete can take it away. Thanks.
I'm not sure I know what to do with that introduction, but hi, everyone. I hope that you're staying awake and caffeinated and enjoying the extra time with families. Hopefully that you all are safe and well. I have my my headphone mic on today because I've now realized through the coronavirus that all my children know how to open the doors to our bedroom and bother us at any given moment. So hopefully if you hear knocking or screaming, you won't get as much of an audio because I've got the headphones on. I want to talk a bit about board certification. This will be the most intimate talk, just in that there'll be, like, there's a little over 130 of you on here out of the 400 and some. So I will generally make assumptions that people who would come to this kind of talk have interest in pursuing board certification with our board or another, in neuropsychology or something else. So I want to at least give you a broader look at how our board certification works. And I've broken up the lecture into three parts. I want to give you a history of the development of the board and then walk you through the examination process, including as many do's and don'ts as I can give you. And then a little bit of data on the pass rates and benefits of membership and things like that. So we have an hour and a half. I would tell you this, I have given this talk before at NAN and INS and at this conference back in the day. And I'll tell you that the way it had historically gone is we'd get some amount of time. I would stop 20 minutes before the end of the time allotted, and there'd be 60 or 80 people in the room, and 20 of them would queue up and want to then ask questions specific to their own background and their own journey and whatnot. And invariably, we would get yelled at by the next speaker, who would say that we're in their room and please get out, because this is a personal process for a lot of people, not only to understand the certification process as best as possible, but how their credentials line up and questions about studying and whatnot. So what I would then do in the years that would follow is to try to incorporate what people were asking me into the next lecture, so that those people wouldn't feel like they had to ask a question and that information was covered, and it never worked. So people always have questions of their own, and I work for you. I would say my role as the exam chair for the board is that of shepherd. So I'm just here to get anyone who wants to get through the process through it, and to answer questions, be transparent, and help you along the way. I don't do a lot of board exams anymore unless someone's flight's canceled and they just need someone to fill in. So I'm in a good position to really help people navigate the process. So with that said, what Justin and I were hoping to do is to do the background on the academy, take a 5-minute break, walk you through the examination process and the stats associated with it, and then hopefully leave a good chunk of time at the end to field people's questions. But if you want to, maybe Justin, can you jump in and just say a word about asking questions anonymously, just for those who don't know?
Absolutely. So we will be fielding questions at various points. Dr. Dodzik will ask for questions, and myself, I will be monitoring the Q&A, and either Dr. Dodzik will be reading those, or I will read those out loud. So if anyone has any personal questions that they would like to ask and they would like to be anonymous, please go ahead and write those in the Q&A and select send anonymously. That way we can answer those questions without showing your name. Thank you so much.
Yeah, I'm always struck by the fact that many people's questions are very similar, even though they think it's unique to them. A lot of us have come into the field in a variety of different ways. And I'll say one word about passing certification testing is that my experience has been that while there are people who do not persist in the process, either because they don't pass or they would need to retake something again and they just don't feel like it's a good fit for them or that they align, every single one of those people that I remember, and I've been involved for several years now, it wasn't that they weren't competent. It was that they were competent in something else. And that might be clinical child, school, health, rehab, or something different. But I very, very infrequently found that people who get to the level of wanting to put their credentials out for review by their peers were not competent. That's not been my experience. They just oftentimes did neuropsychology, but did something else more. And many times we've encouraged them that they're a better fit for a different specialty. And I think that sometimes that plays itself out during the process as well. So I certainly want to encourage people to seek board certification and try to talk about as much as I can what I think the benefits of that are. But let me first give you a little background on the American Board of Pediatric Neuropsychology. My slides are text heavy. I will not read them. It's not my intent to read them. It's my intent to make sure that you have that information at your disposal, because I think it does give you a lot of transparency about where we are as a field, why we pursued this when we did, and how the process is structured, how it is scored. Knowing the scoring of the examination process is often really helpful for people in order to know how to study and prepare. So I want to make sure that you have all that, but I probably won't spend a ton of time reading it. There are, in the historical context, the Academy came about, well, the board came about mainly because all board certification in neuropsychology is relatively new. You can trace it back to the 1980s, and very shortly within the first board certification body, AAPdN, coming about, there was a second board certifying body, what's now AAPdN, or had historically been AAPdN, and then a decade later, there were a lot of debates about exactly where pediatrics fits into the examination process. And I want to talk a little bit about those issues because I think they're very relevant to how we think about ourselves as clinicians, but I also think it's telling on how the field has evolved. So there's some different issues, and what happened with the founding members in the early 1990s was they were members, several were members of other boards, other specialties within ABEP, and were desirous of submitting cases of very young kids. So when they were told, though, at the time that 0 to 5 was not a level that, not a case that would be acceptable for demonstrating competency in neuropsychology more broadly, it was, I think, troubling to them at the time. And I think people think about this as clinicians, like, what are we as neuropsychologists? Are we people who give neuropsychological tests? Are we people who understand neurodevelopmental and neuropathological conditions in children and how to diagnose, fully assess, treat, and care for children with neuropathological conditions. And I think we're the latter. But at that time, there weren't a lot of instruments available for very young kids that really fell into the purview of neuropsychology, either because they had not been, they were older child instruments that were not yet downwardly extended. They were thought to be more developmental instruments as opposed to neuropsychological. But 0 to 5 is my sweet spot. My preference would be that I never see a kid over the age of 11 and that they never bring their parents. So my goal is just to work with children, and I think the experiences of younger kids and the pathologies that they come in with, whether they be something near and dear to me, like complications of prematurity, or, you know, autism, dyslexia, or ADHD, which often have their first assessment at much younger ages, that is really my sweet spot. So I think that was true of people who were desirous to sit for boards at the time and were basically told, if you can't give these types of instruments, you can't submit it as a neuropsychological assessment. And that did not sit well with what young people, especially who work with younger kids, thought of as what they did for a living. So with that backdrop, many of them got together and decided that it was time to form a board that was more exclusively pediatrics and how people demonstrate competency in that area. And I think that's the hallmark difference of this board, is that everything, every element of the assessment process is designed specifically with that in mind. Now, when you ask questions on a written examination about structures within the brain, yeah, they're going to be applicable to adults as well. But, and I would say, you know, when I teach courses in neuroanatomy and neuropathology to graduate students, doctoral level graduate students, I know I'm just teaching them adult stuff. I'm saying the brain is already formed, and here's the best way to understand where cranial nerve root comes out and how those roots can tell you something about lesion locations. But I always am quick to say, in the developing brain, we're going to have this whole conversation again when we want you to understand the neuropathological conditions of childhood. But at the application process, at the written examination process, in the practice samples, and in the oral examination process, the intent is that you are going to be examined more specifically in your competence within that area of pediatric neuropsychology. In that time, if you go back a bit, and again, this is 30 years ago, one of the textbooks, and if you're, I'm 48 years old, so if you're in the ballpark of my age, these were texts you'll be familiar with, but in Muriel Lezak's textbook, there was a notation in her first version in the first chapter, which said, the assessment of children and the consideration of brain disorders presenting prior to maturity have their own conceptual framework, methods, and data, which are outside the scope of this book. And that was my graduate school experience, is that I had people who taught me things about child and adolescence, and I had people who taught me things about neuropsychology, and nary the two would meet. That thankfully is not the case now, but even as you're looking back on what the research and the instrumentation was, the batteries that were being used were variations on themes of developmental or other cognitive or academic instruments. The NEPSI wasn't available commercially in the US until 1998, and 10 of the largest journals that devoted to pediatric neuropsychology in part or in total were not even in existence prior to 2000. So this is ever evolving as a field, and it's not anyone's fault that at that time there was a different view about what pediatric neuropsychology is, and are you competent to be a neuropsychologist if what you do is young children. So in '96, there was a meeting by some of these same members at the World Conference in Pediatric Neuropsychology, and there were a lot of concerns about how much attention is being paid in the graduate school level to pediatric neuropsychology, conditions of neurodevelopmental and neuropathological conditions in children, and a lot of downwardly extending adult instruments into assessment batteries with kids. And the competency methodology at the time was a more general competency in neuropsychology, not specific to peds. In fact, what one could reasonably argue, and I'll certainly defer to if there's any AAPdN colleagues on this conference, or if you just want to reach out to that academy as well, that there has been a broad shift to moving away from feeling like you can work at a VA hospital and only see adults for your entire career and call yourself a neuropsychologist, but you can't work at a children's hospital and always see children without then demonstrating that you know something about lifespan neuropsychology. I just don't think that's the way we practice. And I would tell you that in the 2015 APA practice survey, people who work with kids are a minority in any aspect of it. In that practice survey from 2015, out of the 100 and some thousand neuropsychologists, psychologists rather, 6% of them primarily work in areas of neuropsychology. So there may be 6,000 self-professed neuropsychologists in the United States or something in that number. And in that same practice survey, 14% of people surveyed work with children mostly or exclusively. And so there's not we are definitely the minority within the field of psychology broadly. And in the last 2016 practice survey for neuropsychology, 50% of people surveyed in that said they never work with someone under the age of 13. And only 5 to 10% said that they frequently or mainly work with that age group. So it doesn't really matter what aspect of psychology you're in. It's not a lot of us who are really working with kids exclusively. So the feeling was, even at that time, that there needs to be some attention paid to how you demonstrate competency, and that a knowledge of adult neuropsychology should not be a gateway to knowledge of pediatrics. And I say it, and I joke around with all my students, like having to deal with the parents is the worst part of my job. I love the kids. The kids come in, they're not self-aware. They'll do pretty much whatever you ask them to do. And they're more than happy to do it. The first time an adult walks in, it's like, oh, is this the memory test? Oh, I'm horrible at memory. I'm not going to do well at this. Like you just don't see that kind of thing within kids. And the consumers of the information that you produce in a pediatric neuropsychological evaluation are often much different in terms of it being parents or schools versus an adult system where it might be, their job or agencies within the government or disability. Knowing the consumer base is a big deal as well. So in terms of 1996 and from then on, there was this belief that it should be evaluated as its own area of competency. And that's not that far out from the same thing happening within ABEP. I think it was 2000 or somewhere between 2000 and 2002, where the child and adolescent practitioners within broad clinical just said, we think that child and adolescent should be its own thing. And they got up and they did it. There were, I think I've sort of touched on this now, but they didn't think that at the time there was enough consideration to who's consuming these evaluations, what are the allied disciplines, and that all that stuff is something that you need to be familiar with if you work as a pediatric neuropsychologist. And, I've been listening to talks at NAN and INS and within our own academy for years now. And everyone has a little different spin on how they handle IEPs. In our board, there are a number of school psychologists who are practicing pediatric neuropsychologists, but their academic discipline was school. And they understand IEPs a lot better than I do, coming from a neurology, neurosurgery practice background. But I have learned it as best as I am able, and have been, humbled by my lack of understanding of the educational process for kids and what the limitations are. But I've always felt like it's my job to learn, not my job to criticize, because the only person I work for is going to spend 6 hours a day at these places, and I want to make sure that they're getting what they need and that the consumers of the information understand it. So in terms of the examination process, what had come back in the 1990s was there needs to be this thorough review. And, the Houston conference guidelines were 98. So it's not like this was that far off from being contemporaneous. but they wanted to review the graduate coursework, the internship, postdoctoral residency fellowship, how people are engaged in continuing education, and their scope of practice to determine whether they met that criteria for establishing competency on the first incarnation of the examination within our board. It started with a multiple page examination, application, and a written multiple choice exam. And that is a spin. So they weren't, at the time, they were not using practice samples in oral examinations, but rather doing a review of your credentials, but also a written examination process. In 2002, after several years of the board persisting and taking on new members, they had meetings. This is pre my time, but they had meetings and said, yeah, there needs to be some review and update of the written examination. And guys, that is an ongoing process. Every time they change something within the ethics code, or when the ASD diagnosis shifted, all the questions shift. When some theories go out of favor or not widely taught, they become maybe still accurate data and maybe still meaningful data, but not widely disseminable data. So the examination is always being redone, and that's been an ongoing process, but they included clinical vignettes to the application process, a work sample, which could be an intervention assessment or written work, and an oral examination component. So that, in that sense, it really evolved into what the only other board doing that something similar was the neuropsych board within AAPdN. All AAPdN specialties don't assess their membership quite the same way, and not all have a written examination. And I think that that's fine. It makes sense to me why some groups would and some groups wouldn't, but it became a more a deeper breadth of evaluation after this new process came about. The board also engaged Marty Rolling, who, again, those of us who work broadly in neuropsychology for some time now will know his name, but he has published repeatedly in the area of board certification, and more specifically why people persist and why they don't persist. And one of the things that he said when reviewing our application materials and our reconstruction of the examination at the time was that the idea that people had to complete one stage and then wait a certain amount of time and complete another stage is the #1 reason why only 15 to 20% of people at the time finished their board certification in neuropsychology. So there wasn't a large group of people persisting in the process, and it was taking 2 years plus to get through the process. I'm not here to tell you that's a good idea or bad idea, but what I'm here to say is that was not the feeling of our board. Our feeling was that we wanted the persistence rate of people who are availing themselves to review to be higher. And Marty's, one of his recommendations at the time was that you make the process sequential, but you don't make them the same kind of timeline. So in theory, within AAPdN, and this may be not always feasible, doable, or palatable for people, but in theory, if you pass your application and you pass your practice sample, you could do the written multiple choice exam and oral examination together at the next offering. There's not a reason why those two parts of the processes needed to be tied to each other in any sort of sequential fashion. So that was one of the major changes that occurred. Now, one of the things that happened with the board process at that time was not only was it more consistent now with what is done in other medical boards, but the board voted, how democratically I don't know, but the board voted that all members who only went through the application and the written examination would go back and complete all stages. And so if you meet somebody in AAPdN, they went through all of them. There's no grandfathering, and that was I think a wise move in terms of parity and equity, but I think also a bit of a painful process, because there were people who probably didn't vote that way and didn't stay in. There were people who did not or could not persist in the new process. And what went on were people who were all examined in the same fashion, and I think increases the reliability of what you see of the process for the membership. But it was a difficult time. I also think that, and this is my understanding of it, is that there were people at the time who probably the issue was that they were more in either neurology or school, and they really wanted to specify this as being a pediatric neuropsychologist as opposed to something allied. And I'm from Indiana, but I live and work in Chicago and have since I graduated. And I would tell you that this is very true of what happened with sleep medicine at the time. The Sleep Medicine Board, American Board of Sleep Medicine at the time, had dentists and psychiatrists, PhDs in psychology, and in other medical disciplines like pulmonology and internal medicine and neurology. And when they joined the American Board of Medical Specialties, that they also went through that process. I was most of the way through seeking certification in sleep at the time. It's always been a passion of mine, and thankfully was told, hey, look, it's not going anywhere. Like, they're moving to this new academy, and so it's just going to be for physicians. But it is unusual for things to start with a little broader base. This just got moved into only being for pediatric neuropsychologists. So the process itself was changed, and they also widened the practice to include things like authorship of a test or book in the field that could be used as a practice sample, in addition to a neuropsychological assessment or therapeutic intervention, which all could be part of the practice sample. In 2009, the oral examination was then updated again to move away from just having ethics vignettes and into fact-finding, where there can be cases presented to you, and I'll talk about it more at that appropriate time, but there could be cases presented to you where you would receive some background information and some test data, and then be asked to form conclusions, select the test battery, and then given data to interpret. And so the oral exam was augmented in 2009 and to reflect that. And since that time, it's been roughly in the same, it's been roughly the same process since then. Just to give you a little bit of background, since 1996, there's 147 diplomas that have been issued. There's 115 active members, diplomates, fellows in the academy in 33 states, Canada, England, Israel, and a bunch in Puerto Rico. We have a nice group down there. There are, at any given time, roughly 25 candidates in the boarding process. Sorry, my typo, I wrote 13 and then put the number 12. Scheduled for last year. I looked through this 2019 to 2020 calendar year, and it was roughly the same. There's 40 people in the process, and there would have been 8 of them evaluated in Las Vegas this weekend. I'm going to talk a little bit more about how the board will deal with the coronavirus and the shelter in place and the unknown future as it relates to the examination process. But unfortunately, we didn't do the evaluations this year at the conference that we had intended. We also have moved to not only doing examinations at our conference and at NAN, but also through cohorts where we have a large enough body of members. So that Los Angeles and a couple of areas in California, South Florida, Chicago, and Boston, where we can set up cohorts. New York has also been done a few times. So we're always trying to think of ways to stop people from travel that would be unnecessary. But we're going to move towards doing more of that probably through Zoom as we move forward in this next year, and we'll test that and see how that goes. But that's the broader numbers. If you want to look at it in perspective, and I don't know how often AAPdN updates this, so I'm in 2019, but there's, again, board certification in our field is a statistical anomaly. You know, you guys do research, I'm sure, and you see P less than or equal to 0.05. There's 112,000 psychologists in the United States, and roughly 4,000 of those hold a board certification with an ABEP, and less than 5,000 if you include the 3 boards in neuropsychology. But there are a number of different specialties, and that continues to grow. And I was certainly pleased to see AAPdN move towards having a special interest group and now a subspecialty in pediatric neuropsychology. So I think the more and more attention is getting paid to the field of neuropsychology, specifically pediatric neuropsychology. But AAPdN would sort of squeeze there in the middle with regards to certification. So if you take some numbers, roughly 14% of the 112,000 psychologists who are licensed in the United States work primarily in pediatrics. It gives you roughly, 16,000 psychologists who work with peds. And if you take the 6,000 self-professed neuropsychologists and say, we'll take that number and say roughly, if you add 3 boards together, there are, somewhere in the neighborhood of 20-25% of psychologists or neuropsychologists seek board certification. And I think neuropsych, generally speaking, has done a better job of pushing that that certification as a demonstration of competency within the area. But we are nowhere near in the ballpark of medicine where, depending on the discipline, 80 to 90% of people are board certified in their specialty. And I don't know that this number has changed a whole lot. I've had conversations with ABEP going back to when Russ Bent was the executive director. I admittedly do not remember how far back that goes, but at least 10 years plus before he died. And it was roughly the same. 3 to 4% has roughly been the amount, the certification for psychologists in the field. And while that's troubling, I think on some level, there's something about board certification, whether there are one board or many, that I think serve purposes for the community. And I want to talk just a little bit about those before we break. So obviously, in our mind, the rationale for pediatric neuropsychology was not to do a general or lifespan. That in the APA, they certify competency in psychology as you have a license, a doctoral degree and a license. Anybody who's been through an APA self-study for a graduate school program, an internship, or a residency will tell you that broad and general are the goals of the APA, and it's an inclusive organization for that reason. It could be argued that that's also been some of the models of board certification in neuropsychology in the past, was to look for general sort of competency in neuropsych or lifespan. I do not practice lifespan neuropsychology. I do not know many people who do. If you can do it, kudos to you. But I go back to my first point, which is if you work at a children's hospital only with children, you're a competent neuropsychologist. If you work in a geriatric memory clinic, you're a competent neuropsychologist. And if you work anywhere in between, I have no reason to believe you're not competent in what you do. But I don't think that I need to demonstrate, or that anyone needs to demonstrate, competency across all age groups to be able to use that term. So that's my opinion. It's obviously an opinion that's shared within my board, but it doesn't have to be your opinion. The process has these elements, and so I'll talk more about those after the break, but there's an application which reviews your training and coursework. We are a believer in the Houston guidelines, but it doesn't include anything specific to pediatrics, so we're never going to be adhering to it unless that somehow changes. And it wouldn't shock me if there is changes to where peds becomes its own specialty or gero becomes its own specialty. And for those of you who took the most recent practice sample, there was discussion about forensic neuropsychology, and I don't know if that's someone's way of gauging level of interest and what people with an ABEP and forensic think about that. But again, it doesn't surprise me that the field evolves, and frankly, it should. There is a written examination which covers 7 different components. There's the neurosciences, which is neuroanatomy, neuropathology. There's a neurodevelopmental piece to it, a diagnostic, psychometrics, ethics, on legal interventions, and then research design that are all parts of it. The way the test works as a preview, it has an item pool of several hundred items that are all categorized into one of those 7 categories, and no category could dominate more than 14% of the exam. And the questions are assigned p-values, so the difficulty level of them is known, and no examination can overpopulate the different questions. So like I'm sure people who are involved with any sort of broad testing can tell you that there's safeguards within it to make sure that the exam is representative of our intent. And then as mentioned, there's a practice sample. Saying a word about it now. Different boards do things different ways. We do a 3-panel examination that lasts roughly 3 hours, as opposed to 3 one-hour examinations in different areas. And I think there's a lot of value to that in terms of inter-rater reliability and how we train our examiners. I'd love to hear from people who have been through the process as to whether or not the panel feels more intimidating because there are 3 people in a room asking you questions. I don't know the answer to that, but my feeling has been that, and I will certainly push forever, that this is a collegial process. If you avail yourself to having your work reviewed by others, you are going to walk out of there, pass or fail, feeling like you were treated with respect. Otherwise, I want to hear about it. Because this should not be a process of assigning someone the moniker of the best neuropsychologist, pediatric or otherwise. It should be about demonstrating competency. And gotcha moments and gotcha questions have no place in that, to me. And at the moment, I'm the one who the buck stops with, so I'm certainly going to make sure that that's the case. The practice samples are reviewed independently by a panel of 2, and if there's a debate, then there'll be a 3rd reviewer who does that. But our examination process, again, as I mentioned, hasn't changed a whole lot since 2010 in this regard. So it's not an ad hoc approach. There certainly, if you took a broad examination in ABN and ABCN, both use written examinations, there may be items on there that are directly related to pediatrics, and they have said anywhere from 10 to 15, depending on which board I've asked at which time. But in theory, if you have a passing score of 70, you could fail all of them and still be considered competent as a neuropsychologist and hang your shingle out to see kids. So our goal is to make sure that we're evaluating these areas not in an ad hoc fashion, but with intentionality. It doesn't mean one process is different. I've moved to the point of indifference when it comes to how many boards in neuropsychology there should be. I had feelings back in 2006 to 2008, much the way I'm sure my ABN and ABCN colleagues had feelings back in the 1990s about why can't everyone work together? Why can't there just be one board? And I was told a story once by one of my mentors of Indiana. And I also went to school in the South. So I'll be honest, I can't tell you stuff. I can only tell you stories about stuff because that's how we all learn things. So the story goes like this. In Indiana, there's the Indiana State World War II Motorized Vehicle Preservation Society. So you want to get into the minutia of people's interests. And unfortunately, now there's also the society, the World War II Motorized Vehicle Society Preservation of Indiana. So there now are 2 different entities within the state of Indiana that are interested in the preservation of World War II motorized vehicles. And the reason why there are 2 is because one group wanted to polish them and look at them, and the other one wanted to use them for battle reenactments, and they couldn't agree on what to do, so they split into 2 boards. Is that a bad or a good thing? I mean, you could join both, and if you had an interest in one versus the other, you probably would be happy in the one that you pick. So I'm not sure that it has to be a bad thing. I'll say one more thing about it. When I was in talks with Russ Bent, there was a time when everybody had this discussions about working together. I learned a lot of things about the purpose of board certification. And I had thought that at the time, well, I'll tell you, I mean, I worked at a neurology neurosurgery clinic, and everybody was boarded, and so the director said to me, all our physicians are boarded. Don't you think you should get boarded? And I said, I guess. I mean, I don't know if I had any feelings about it one way or the other, but they said to do it, and so I went to do it. And Russ said the feeling that they had was, if you have an APA, if you have a body that is broad in general, and their goal is to make people reach licensure as the mechanism of establishing competency in psychology, then what board certification does is something different. It's not about showing who is good or bad. I know many people who are board certified who are amazing, and some that I would not send my own kid to. And I know people who are not board certified and probably never will be, who are excellent clinicians, and I know people who are not board certified that I wouldn't send my kid to. So I don't know that it makes you competent in anything, but I would say this. One of the things certification does is it pushes downward on how we train. So the Houston Conference has something else within inside of it, and that something else that it has is a line of demarcation based on when you were trained. So if you graduated before 2001, you have a different set of standards for training. If you graduated before, people can throw it up on the chat line if they know. I think it's like 85 or 87. If you graduated before that, you don't really have to have any graduate training in neuropsychology because there wasn't any expectation that there'd be that available. So we knew that the field would grow, and board certification does that. What it does is if you have to have coursework, internship training, and residency training in neuropsychology in order to get board certified in neuropsychology, then it forces more residencies to provide that training, which forces more internships to provide that training, which forces more graduate school programs to provide that coursework. And what certification does in any specialty is to force that process. So that is where I think the value of board certification is for the field, regardless of the specialty. And so if there's more of that, forcing more residencies, internships, that is better for our overall training. If it provides the public with more consumers, or sorry, provides the public with more practitioners who are board certified, think of what you're getting. I mean, you right now, the number of board certified neuropsychologists in the entire state of Illinois is less than 50. And we're a state of nearly 13 million people. So if you can provide consumers with more assurances that the provider that they're going to has been at least evaluated in this area, that's a win for consumers as well. So I think that's great as well. In looking at, just for a quick snapshot at the field, the other thing I think that ends up happening when you have these board certifications is it begins to push things. So now there's the graduate school programs need to have more coursework. People are publishing more in this area in journals and writing more books about it, which expands our knowledge. And then you get conferences like this and like NAN and INS and AACN, which provide people with more opportunities to expand their knowledge base. But if you look at what we're talking about in terms of instrumentation, there are, in my last count, 177 different instruments that were available for you to assess neuropsychological functioning. And I won't quibble with people if they have other things that I don't think are, but they like. The point is that there is a tremendous amount of instrumentation. And 61 of those were designed exclusively for kids. So whether they be IQ tests, and I try to break them down, and then there's another 14 to 20 that have been what I would say is effectively downwardly extended into use with children, not all children, all ages, but with kids. And so you're looking at a pool of 75 to 80 instruments that you are probably going to need to be competent in to do your job. And so there's a huge knowledge base that one is needed, and it's ever growing. If you look at who's getting trained, then they list 247 internships in pediatric neuropsychology, Div 4126, AAPdN, APA Division 40, have fellowships. So that at best guess, there are somewhere between 100 and 140 people graduating every year who potentially could be board certified in pediatric neuropsychology. So if you accept those, and you don't have to, but those are the numbers I'm offering. But if you accept those, then since 2005, since we sort of reopened the board for certification after we changed the model, about 10 to 15% of those who could, based on those numbers, become certified in pediatric neuropsychology have done so. And obviously, if you include any pediatric specialist who has gone through ABCN and then gone through their specialty afterwards, that number would increase. But it's still better than ABEP, but everyone's got a long way to go if we want this to be the standard in the field. So I think I've said that. Within our membership, there's a lot of hard work being done. We have, as you can see, current, well, I guess he's not current anymore, but previous president of APA, of Division 40, 2, 5, and 16, 7, now 8 different presidents of state psychological associations, 2 past presidents of NAN, numerous journal editors, and at last count over 5,000 book peer-reviewed journal chapters and articles produced by our membership. It's a body of people who are providing a lot of push to develop our field. Not the only people by any stretch, but certainly an active group. So there's evidence, at least in my opinion, for consumers, for professionals, for students to get board certified, for them to be board certified eligible within pediatric neuropsychology. Again, I think I can hold there for the quick summary. I think I've gone through that. I want to say a little bit about the affiliations before we break. There's an academy since 2008. You could join the academy just from coming to the conference. If you picked the member status, everybody who's boarded in our field instantly becomes a fellow in the academy. It's a conference that we've been doing now for 6 years. We before that had co-hosted one with ABN. There is access to the Journal of Pediatric Neuropsychology from Springer, which is our journal, and you would get access to that. And then these conferences, there's a discounted membership for our academy members with that too. So there's benefits within just being part of that. I always tell people, check your state. If you are in the state of Illinois and you are a neuropsychologist for whatever age group and you are not board certified, you are losing money, because we are paid from Blue Cross Blue Shield physician rates instead of psychology rates, so 100% versus 85%. Now, I don't know if that'll go on forever. I don't know what happens in your state, but if there are other benefits, and there may very well be, either from a ability to use the term board certified or to call yourself a neuropsychologist, or compensation reimbursement, those are other good reasons to check into that process. I'm going to take a 5-minute break and come back and talk a little bit more about the actual examination process, and then field questions. If you put questions in, I'll look at them now and then make a decision whether to jump to them right after the break or at the end. Okay, I went through the questions as well. Let me see if I can work some answers in, because we're at that part right now where I want to talk about the examination itself. So my hope is that this will answer some of those same questions. The application process. So the first step is the application process. And this is where I get a lot of questions after the fact when I do these talks. So there's obviously a yellow brick road, and stay on the yellow brick road is what they told Dorothy and the Wizard of Oz. So if you follow things in the Houston Conference guidelines, where you have an organized graduate program where you have had coursework in neuropsychology, and particularly pediatric neuropsychology, you did an internship in pediatric neuropsychology, a residency, APPCN or otherwise, but a 2-year residency in neuropsychology, you're licensed in the state or province or country where you practice, and you're active in, not a felon, but then you have reached the point where you are eligible for board certification anywhere with any of the disciplines that you would have, provided that you met those criteria and did it at every single level. But that's not really what the aspirations of the Houston Conference guidelines were, and that's not the way that we applied either. I think, and I believe this to be true, is that the goal is that you end up at visiting the wizard. Well, I guess the ultimate goal of this metaphor would be that you end up back in Kansas, but the point being that the yellow brick road got you there whether you stayed on it or not. And what Houston's guidelines really stated, at least the way I interpret them, is breadth and depth. So there is both a vertical and horizontal method by which you can achieve competency. So if your graduate program didn't have all the coursework, but you took additional coursework when you were on internship or beyond, or you didn't have neuroanatomy, but you did brain slicing as part of your structured internship or fellowship, you may still have all the criteria. Because if you look at the way the coursework pieces of this lay out, there's going to be ways of achieving that sort of goal the whole way through. And I think internship becomes the wild card for almost everybody. There's been these periods of time during our field in psychology, more generally speaking, where there's been feast or famine for internship, where there's been more interns than there are sites available, where we've now shifted the other way, where there's more sites than there are interns. And that this is a market force that we as a discipline can't always control. So if I had to pick one of these areas where I got the most questions, it was generally at the internship level of, my internship was in children, but it wasn't in neuropsychology, but I had the coursework and I had the fellowship, or I did a fellowship that was 25% pediatrics and all adult neuro, but I did some pediatric therapy. Like the goal within those Houston guidelines, which have always been aspirational, but I think the goal was that at the end of the day, you could build upon your skills to gain the knowledge in all the different areas, even if you didn't do every single thing at every single stage. I think that's also true for the fellowship process. Many of the, even the market forces involved with fellowship are such that in order for you to have a formal fellowship, you have to be in an area where they are either funded or you're at a practice by which the group that you work with has decided to give you training as opposed to just reviewing your cases. So the hope would be that everyone would stay on the Yellow Brick Road and have organized training and coursework at the graduate level, and then organized training at the internship and postdoc level, and then continue to receive training such as what you're doing today, and work and contribute to your field. But if you can come to the end stage by having different things at different levels, I think that's really what was intended by the Houston Conference. And what I would say this is your opportunity to outline your training. So saying to me in a CV where you went to school doesn't tell me near as much as you're allowed to in the application process, where you give us an idea of what kind of patients that you've seen when you were on internship, and what were the age groups, what was the disciplines, what was the battery you used. Like the application is designed to give you this narrative that allows you to explain how you came to where you are. And that's why it's a 17-page, somewhat daunting process. So I jumped ahead of myself here in the slides. The thought would be at the graduate school level that you would have 1 and 2 by the sheer fact that you went to a doctoral program in psychology. 3 and 4 are things that you'd have to acquire either in graduate school, but internship and through residency. And again, the point of saying what's the benefit of having board certification is that this is where you can see it pushed back. You can see that if there's a discipline board certification in peds neuropsychology, that's going to lead to more fellowships, that's going to lead to more internships, that's going to lead to more graduate school. So it's really here that I think the field has grown the most and contributed the most. But those are the different domains that we're looking for across all your training. There's examples of each level. In the doctoral, people will ask a lot, my program was not APA accredited at the time that I went there, or was CPA accredited, or it wasn't CPA accredited. And they'll ask, like, does that automatically preclude me from anything? It would force you to have some other body evaluating your work. So like if you went through the National Register, they would go through and verify that your coursework was the equivalent. So a lot of times we'll ask people if they went to a program. A lot of times it's an allied discipline. They have some neuroscience training, or they respecialized, and one was accredited, one wasn't, because they don't accredit neuroscience programs. They want to then know if I qualify, if I did a respecialization. The goal of the whole piece is that some external body has validated your work. So you can see on there that APA and CPA are great ways of verifying that your training would meet criteria. The National Register, or CPQ, would be the other way. I'm just giving examples here that you can use on your application to show what kind of courses you had taken. This would be somebody who had a lot of coursework at the graduate level, and they can say a little bit about the narrative within the application itself. On the internship training, again, we have never said in our model that it has to be APA or a CPA, and the reason was because we consider it to be a market force, and people then start making choices where they say I want to go to this APIC internship where I'm going to do pediatric neuropsychology, exactly the thing I always wanted to do, or I'm going to go to this APA community mental health center and maybe give some neuropsych instruments, but not really be able to see patients the same way. And my push would always be this. We have a rigorous practice where I work. We do 10 to 12 batteries per week. So while that is a lot within our department, imagine how much faster you acquire a skill set when you've been exposed to 100 patients in a year or more than if you've been exposed to 10. You are going to learn so much more, so much faster when your volume is high. So I think on internship, one of the things that happens a lot is that people are then making these choices about going to APA where the Apex site might have actually given them much better training. So I have not been tied to APA. I know the other boards have had their own sort of struggles with it as well, particularly during that time where there was a glut of grad students and not enough internships. I would encourage you, if you're seeking board certification through ABN or ABCN, ask them directly. But that has not been something that we have been married to. Postdoctoral training, continuing education is not sufficient to build a skill. Continuing education is for skill maintenance, not acquisition. So you're gonna learn a lot at a conference like this. You're gonna learn a lot at NAN if you go to NAN, but you're not gonna learn how to be a neuropsychologist. That is done through an organized, systematic training where you have to demonstrate the competency, not just go to a workshop. So the training is 2 years postdoctoral. That is required. Now, again, sometimes if someone has a really strong internship or really strong graduate training and they've been supervised in a 1 year postdoc, and then they get individual supervision for a second year that they don't need because the state only requires them to do 1 year, that person may still be eligible. It's going to be how the committee views how much organized training you had at all levels, not at any particular one. So fellowships, again, on the application, you're going to have the opportunity to let the committee know where you specialize. This is a key factor. It's not just about you demonstrating competency through the application. This is the signal to me of how to set up the rest of your evaluation. And here's what I mean by that. We have people who work in, boutique practices where they see, learning disabilities, ADHD, private practices. We have people who work in, neurology, neurosurgery practices, like I've spent most of my career. We have people working in departments of psychiatry at a hospital. We have people working in oncology. We have people working in rehab, and they're all going to have a very different experience. In addition, while I may love working with younger kids like 6 or 7 and under, you may not. And I want to make sure that when you tell me what you've done in your application, not only from your fellowship, but also through these clinical breakdowns. Part of what's going to be on there is not only you doing the vignettes, but you giving us a sense of what you see and how often you see it. That will give me the opportunity, such as this in this practice description you see here, to know who to pair you with. So in an ideal world, what we want to do is make sure that if you're coming at this from an oncology practice where you see a lot of kids with leukemia, that I give you somebody on the committee who knows what you're going through. By the same token, if you practice in Canada or you practice in another country where access to care or utilization of care or even language or cultural barriers are different, I want to make sure I can match that. I'm not always as successful, but I really talk with the applicants at this part to make sure that I understand where they see their area of competence within the field and that they get put with people, at least one person on their committee who would understand that. And I again, for those of you, there was somebody who posted a comment about working internationally. We have several people work internationally. We have numerous people in Canada. We have people in Europe. And our goal is to make sure that somebody at least has some understanding of it, of what your specific daily work would look like, and what challenges you would face. And if there are cultural, ethnic considerations to the testing, which there are almost always. There's the number one diversity is probably economics, but whatever you're coming in with, I want to make sure that you're getting married. So you don't have three people who work in neurology, neurosurgery with stroke and epilepsy, and you're coming in with a case with dyslexia. You should feel that they have some similar life experiences in part or in total. So the application is really important, not for you to paint a picture of stretching the things that maybe you actually do, but really just showing us what you do so that I can use that to pick your examination team and reviewers going forward. So hopefully that makes sense. This is a quick example of what a vignette might look like, where you get a little bit of a description, you get to pick the age of the child, and then you would be asked a few questions about how you think through things. While that is scored, pass, fail, it is also, again, something that we use to try to help pick people who use similar instruments. I would love it if I lived in a world where people had general agreement about the battery of tests that you should use to assess ASD. We do not live in that world. I would love it if people's report writing style was roughly the same. We do not live in that world. So what I'm trying to do is to make sure that there are people who are on your committee who are gonna be as closely aligned to the way you do things. And again, that is making sure that you're evaluated in your area of competency within Peds Neuro. I think I have belabored this. Once it's approved, you are going to then be sent a notification by me to join for the next step. And the next step is the practice sample. This is the way that we get to look at what should be the outcome of your job, right? I mean, I don't write a report for every single person that I see, particularly if it's in the hospital, but I do something with every single thing I see. So this is a way of us getting a look at what you do every day and what your final work product is. We really try to have our turnaround time match the distance to wherever our next oral exam is, but 90 days is what I try to encourage people. Don't submit me a practice sample 2 weeks before NAN, because it will not get reviewed in time. So the purpose is your day-to-day application of skill. Again, all of our reviewers have their own feelings about how people write report and what they should do, and whether they write first-person letter style, whether they write classic domain style. If you remember probably some of your early reports in graduate school, you had to assess all domains, even if they weren't relevant to the referral question. That's just how people did it. And reports could be, 20, 30 pages long. I don't want to read a 35-page report, but I can understand its value depending on what the referral question is. We don't score based on writing style to that degree. But the thing that you submit really should reflect what you do day to day. When people go off the rails and start giving us cases that are either forensic in nature or something interesting that they saw only one time, that does not make for a good work sample, because I'm going to use that as an indicator of this is what you do, and I'm going to match you accordingly. So lots of things can work really well as a practice sample, and we'll talk a bit about them. So typical work reflects something that you do. Okay. Let's move on to some do's and don'ts so that we can get to this. These are things you can just read. They're just things that you need to know for putting that work sample together. But there's a Likert scale of 11 different criterion that they look for when scoring your sample. And then again, it goes to 2 different reviewers, and they'll review it independently, and then I'll find a third person if there's some disagreement. Let's do some do's and don'ts. Okay, so do. Present something as typical of your work. If you do ADHD and learning disabilities, I think those can work. The challenge with those types of evaluations is that you have to then be able to demonstrate how your work is within the purview of a neuropsychologist and not a clinical psychologist. So if you're relying just on rating scales and maybe a continuous performance measure, that's probably not a reasonable battery to pick. It may be what you do. It may be something that you do well. But pick a case that's going to demonstrate your skills as a pediatric neuropsychologist and is typical of your work. Definitely present case history. You will be asked to provide not only all of your raw test data, but all of the records that you relied upon to make your decision. So there may be medical records that you didn't rely upon, but you're going to give us all the records that you did. We're going to get all the test data. Deal with conflicts in your data. I cannot tell you how many times I've read a practice sample where someone has said, the coding was a 6 and the symbol search was a 14. So their scores varied between low average and high average. No, you need to explain why those two subtests are different. And it may be motor that defines them, and you may explain that with several other tests, but you cannot just leave 3 tests that deal with one area out in the wind and say they're variable. The reader needs to have an understanding of why. Or if you don't know why, maybe you just don't know. I mean, we've all had people that have come in where we don't know exactly why their data is the way it is. Don't pick that case. Pick the case that lines up with the test that you gave and you had complete background information. Interpret all the potential alternatives to why you're seeing things. If you read books like Ida Subarin's Neuropsychological Evaluation of the Child, she talks about the idea of phenocopies. And if you've gone to lectures, you've seen this, where epilepsy is, especially generalized or complex partial, is a phenocopy of inattentive ADHD. They can look very much similar on the test that you would give. So you have to explain what all the different alternatives are. Provide your diagnoses. There are people who will apply who work in schools. There are people who apply who work in areas where they do a little more boutique work, and then they don't always provide a diagnosis. Don't do that here. I mean, give us the full picture with all of the relevant referrals that this kid's going to need, all the interventions that you think are evidence-based for them. And this leads to the next issue, which is that somehow there's become this lore that everybody has to write the same report. And we don't, none of us do. My forensic reports look nothing like my clinical work. And if I know a school wants something different, I write it the way the school wants it. If I know it's going to a pediatrician, I write it the way they want it. But you are giving it to a board. So don't leave the stones unturned. You may say to yourself, well, you know, this kid had an ADOS that was done by an autism clinic a year ago, so I'm not going to repeat it. I could see it passing, but I'm probably going to ask you why you picked that case. I want to see the case where you did the things that are evidence-based to answer your question. You help us understand how the conflicts in the data were resolved. You provided us with a diagnosis and all the recommendations. So if you have to augment the report that you gave to the family to show how you dealt with all these different context for the report that you submit to the board, do that. I don't care if it's the actual report the family got. I care that it's representative of your work, but also that it answers these types of questions, which leads into the don't. Don't pick cases where there's limited background information. I know we all go through this every day. I know you can't get every piece of information that you might want, but if there are big holes in what you're giving us, don't pick that case. And definitely don't pick the case where you evaluated them a year ago and you're just going to refer me back to that previous report that's buried somewhere in your background information. I do not want to go back and forth trying to find all the different data. So either restate the data from the previous report so it's all in one place, pick a different case. Don't rely on broad instruments to inform multiple domains. I don't want to see how, and not like any of the reviewers want to see, an IQ test being used to explain language and spatial skills and attention. I understand that there are subtests on there, but you have a lot of instruments at your disposal. Pick the ones that you need to be able to build the domains that you need to assess. Don't pick a case that's exclusively clinical or school. You could do a neuropsych evaluation on someone with depression, but then you're going to invite the question of why, right? You can do one that's exclusive to a learning disability, but you're going to have to answer questions about how this work is representative of a neuropsychologist. We all do it. The #1 referral at the neurology neurosurgery clinic is ADHD. It's the most common referral on the planet. So it's the one that we see the most often. So they make good cases, but I would just encourage you, try to pick the one that has a couple of little conflicts within it. You know, maybe it's a little bit of LD, a little bit of ADHD, or maybe it's a pretty clean post-concussive syndrome or pretty clean epilepsy. Reactive attachment disorder in a kid with minimal early medical information may be interesting, but it is fraught with problems on my do's and don't list. So pick the one that's going to give you the cleanest data. The written exam. This is the part that scares most people. It is not the part that people fail most often. So people get afraid of it because it's a psychometric test. But as I've said, it's been designed in such a way that it can only assess limited amounts for each domain. And the written examination has one thing going for it, which is that I can get it proctored almost anywhere. So it's the one thing you don't have to travel for. I can find somebody who's in our board who can proctor it for you, who's near you. And so if you did fall into a position where you didn't pass it, you don't have to wait till the next NAN. I'll get a proctor that's local to you. And so I would tell people that's probably the least scary thing. Readings are on our website. There's a full study guide on our website that you can download. I always tell people, review neural development, review the APA ethics codes. They're low-hanging fruit. Most people, when we developed this test, we had people take the entire item pool without studying so that we could see what is your walking around knowledge. And we really tried to pull questions that assess people's walking around knowledge as opposed to the minutia of neuropsych. So I would tell you, when people take the test, and tell me if I'm wrong if you get to that point in your career, 25% of them you'll know right off the bat. 25% you'll narrow it down to the point where you're pretty darn sure. 25% you'll go, you know, that's a super reasonable question. It's not exactly what I do. And then 25% you'll go, that is a reasonable question, but I just don't remember that. And the whole point of it being that people are so used to in our field getting A's on everything they do. And on this test, you need a 70. And if the exam does what it's supposed to do, then all the scores will be tight. And I will tell you that the lowest scores I've seen are low 60s, and the highest scores I've seen are low 80s. The exam does what it's supposed to do. I would also tell you that the fear is probably unfounded. People's feelings about how they're going to do and how they actually do are almost unrelated. I would also tell you that preparing for the written at the same time you're doing the oral is probably the right thing to do, because you're going to be studying all the foundation knowledge at a time when you're going to be asked to go in and get it. So I think I've said enough about that. The oral exam. There's multiple pieces to the oral exam. So it's a panel of 3. In the first stage of the exam, you're given the opportunity to discuss your background. So you're given the opportunity to say words of, to walk us through your training. Think of it this way. Your application is what you did. And your written examination is a body of knowledge, but let's all be honest, there's some engineer who passes the EAAP every year. He thinks it's fun. So that knowledge is what you study. Your practice sample is your work, but I don't know who read it, right? I don't know how many people you had look over your work, even though we ask it to be yours, but I don't know. But the oral examination is your opportunity to show that you walk and quack like a duck. And this is the duck test, if you want another quick analogy. So part 1 is the chance where you get to provide your background. Take a minute before you do this and sing your praises. Walk yourself through how you got to where you are, all the training that made you who you are, and take that time to really say, okay, this is what I did at each level of my training, so that the examiners can understand why you feel like you're a neuropsychologist. And if you take that time, it will come through. And if you don't take that time and you give broad strokes, you'll be sitting there being asked question after question about, okay, well, what did you do at that position? And how was that relevant? And what was your training like? And what instruments did you use there? So take the time to walk them through why you are a duck, and that part will go well. There may be questions, and I always give examples where they ask you to reflect upon, developmental factors that are affecting pediatric neuropsychology, differences at different age groups, or how does neuropsych differ between peds and adults, and what are the problems with downwardly extending instruments? So you will get these opportunities to discuss in parts 1 and in part 2 why you're a duck. Part 3 is the practice sample. In a brief statement, I'll tell you this. The practice sample almost always goes like this. You walk in and they start asking you some questions about, well, how'd you pick this case and how does it reflect your work? And about 5 minutes into you talking, they'll all just start asking you questions, because what people want to do in an oral exam is to highlight their strengths. They're going to come in and say, look at all the great things that I do. But what you'll find out in the oral exam is that they don't care about that. Like, if you did it right in the report, they're not going to ask you about it. What they're going to ask you about are things that they find that are conflicts, and places where you made one recommendation for an intervention, but not another. And it may be that you thought Orton Gillingham was a better methodology than Lindemuth Bell, and they may agree with you, or they may think they're equivocal, but they're probably going to ask you why you picked what you picked. So I always tell people before the oral, go back, reread your practice sample, reread all the accompanying data. You will know the most about this particular kid in that room. And by so doing, look at what you feel like you could have done better or didn't do well. Go back to my slides and my do's and don'ts with your case and say, did I do this? Did I deal with this? If not, have an answer. If you can answer in the moment why something you did in the report was wrong, they're not going to care. They may wonder why you didn't fix it, but if you say, now that we're talking about it, I see it this way, you've demonstrated the knowledge, and that's what they're looking for. And then the fact finding I've talked about, they'll give you you can either be neurodevelopmental or a medical case. If you're like me and you work in a medical setting, the medical is the way to go. If you're like a lot of people who work more neurodevelopmental, where we're talking about ADHD, learning disabilities, things like that, pick that. Pick the case that reflects what you do. I would argue that probably everybody could pass both of them, but save yourself the stress level and pick the one that fits more with what you do, because you'll be more familiar with the findings. The one thing I want to say about the scoring of the oral, and I'm hoping I'm getting some of these questions because I've got them up there, but one thing I'll say about it is that they all scored independently, even though they're in a group. So even though they're in a group and they're all talking to each other and talking to you, and it's a dialogue and it's collegial and it feels that way, hopefully. When you leave, they're all going to score the whole thing independently. They won't know each other's scores until I get it, because we try to deal with outliers this way. You can either pass 2 of the 3 examiners with a score of 70 on their scale, or you could pass with a total score. And the reason why we do it both ways is just in case there's an outlier. I mean, again, I feel like we're all good people, but some people get pet peeves about stuff, and I just don't want to deal with that. So I want to make sure that as they're looking at the different criteria and applying the criteria to each section, that they are also on the same page. So if you get an outlier, 2 people pass and 1 people fails, you could still pass on the total score, even if you failed 2 of the 3 examiners, if it's all very close. So I use both the total score and or passing 2 out of 3. Give you some rates, and then I'll look at your questions again. If you're looking at the exam statistics, the pass rates are 85% for the application stage. That is basically exactly what it is for ABMS. And I think it's because most people have already talked to me before they decide to apply, and they've either decided that they're not a good fit, or they are a good fit, or if they had something to work out or remediate, it's been discussed. The written examination is roughly 80%. The oral examination is 78%. I would say the thing that I see failed most often is the oral. It's one of those things where I also tell people, if you're willing to persist in this process, the oral examination is going to be knowable to you. The next time you come back through, it's not going to change. It's a case that you're going to bring, and it's a process that you've now been through. And the pass rate the second time through for the oral examination is quite high. So I always tell people, like, if you can stay with it, if you can persist with it and keep your ego to a minimum, you're going to be treated well in this process. And the overwhelming likelihood is that you're going to pass. That's what the data shows. So overall pass rate at each stage is roughly 85%, roughly 70% pass on the first try, and it's 90% people who persist. So persisting is really the key. Let me look at your questions while we're talking and see if I was able to work enough of them in. One of them is, I think the nuts and bolts of the question is, does it vary by state who can use the term neuropsychologist? And it does, not in a lot of states, but we've had conversations in Texas, Louisiana, and Florida about the use of board certification, and I think in Texas more about the use, in Louisiana about using neuropsychologists. You can demonstrate competency without being board certified. So I don't know that really applies. There's the person who was asking me a question about being trained in the Caribbean, but let's do that one offline. So dial back around with me, because I might need more information than I can get to. The idea of somebody's asking about whether the board would consider alternate training pathways, multiple psych assistantships, part-time internship. The part-time does not have that's not a requirement that every state has rules for part-time and full-time. And if you complied with your state, it wouldn't make any difference to me. We have lots of people. There's a question about people transitioning between clinical and neuro. That does happen quite a bit. That is definitely a great person. If you to dial back around with me, I can talk to you more specifically. But like when the fielding was doing respecialization, there are a number of people who had respecializations from fielding who have gotten board certified. So it is not a stumbling block on paper. Need to submit undergraduate transcripts. That's a good question. That has always been historically true of the application. I don't really think there's a lot of weight given to them within the process, but every now and then people did things at the undergraduate level that were in neuroscience related, and they didn't do as much at the graduate level, and they talk about those. We like to see that documented. I'm not looking for anything more specific than that. So please ask them about factors and considering with the various boards. I know we're running out of time here. I don't do your worldview, right? I mean, I think board certification is meaningful. Particularly, as I said, in Illinois, if it's going to lead to a pay increase for you. I think it's great for getting on forensic panels, for state panels, like in Louisiana, that does help you. But this isn't an advertisement for you to come through our board. So I think talk with me, let me help you to understand what our process is, and then do the one that feels right for you. I've never been in a situation across any of the states or anything like that where they preferred one board over the other, and like Illinois wouldn't care what board you went through for the pay here. I'm not reading one about 2 years of formal requirements. Yeah, it just doesn't have to be a 2-year formal postdoc. Justin, is there anything that you feel like I missed on, or things that you think I need to answer, or do we feel like we got the bulk of them?
I feel like we got the bulk of them. There are a few that are more specific that I think would be best for people to email you directly.
Yeah. I work for you guys. Shoot me. This is the reason why I'm in this position. So my only role as the examination chair is to help you guys make decisions and feel like it's a transparent process. So there's my address and phone number and email, and you can reach out anytime with questions specific to you. But hopefully I got you some broad stroke feelings about this, and enjoy the rest of the conference, and I will sign off. Thanks.